Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello, my name is Dr. Shanda Blackmon, and I'm the director of the Baylor College of Medicine Lung Institute. Today, we're here with Dr. Sunjay Devarajan, and he is an expert in non-tuberculous mycobacteria, bronchiectasis, and cystic fibrosis. Today, we're going to focus on the non-tuberculous mycobacteria. So welcome, Sunjay. Do you want to tell us anything about you?
Yeah, thanks, Dr. Blackmon, for the introduction. I've been an assistant professor with Baylor College of Medicine for a little over 5 years, and I like to start by saying my career got started off inauspiciously because 6 months into my starting, the pandemic started. So I became a full-time ICU doctor for a while, and that was, a pretty formative time. So by the time we were sort of able to get our bearings and come back into the lung disease world from a career standpoint, I was already felt like a mid-career, weathered doctor.
Yeah, you've been through a lot.
It was interesting. It was an interesting start, but I'm happy to say that it seems to have ended happily, or it's going on happily.
Good.
And I think there's a lot of pride in what we've been able to build on the pulmonary side of things.
Yeah, so you have a dedicated clinic that just takes care of patients who have non-tuberculous mycobacteria. Is that correct?
That is correct.
And it's a multidisciplinary clinic, and you work with infectious disease specialists as well, right?
That's true. Yeah,
Good.
it's so what the patients can experience when they come, and we kind of designed it around what we thought patients would appreciate, and I think we were right on target with that, is that these patients tend to get bounced around quite a bit between specialists, specifically, the pulmonary doctor who often does the sputum sampling or the bronchoscopies and often makes the diagnosis. And that same pulmonologist may not be comfortable managing the disease, the antibiotics, and so on. And they end up referring to an infectious disease doctor who may or may not have expertise on the subject. So we thought it was a really big value added to have both people in the same room at the same time with the patient, come up with the plan right there, and get that plan going.
That makes so much sense. And I bet you're a great resource for the whole area of Texas and maybe even the United States.
Yeah, and I think I'm happy to say that we are kind of making a name for ourselves. This was truly a field of dreams, if you build it, they will come thing.
Uh-huh.
And, the history of NTM management, at least recently, in Texas and in the Gulf Coast, where actually we have some of the more problematic cases, just regionally speaking, is this emergence of the UT Tyler program. So UT Tyler actually, because of a very focused microbiologist, ended up being sort of the mecca of NTM treatment for the nation. And I would say probably up until now still holds that title, maybe along with National Jewish in Denver. And, when I started here, I think I may have asked this even as a fellow, at least as a whisper. And I thought to myself, I'm in the Texas Medical Center. I'm in Houston, Texas, the biggest, baddest medical center in the world.
In the world.
Why are we sending patients to Tyler, Texas for a very specialized problem? So it sort of started with just asking the question, and the next question was, why not me?
Yeah.
And I think that's really how it got started. And it fit really well, with my interest in bronchiectasis and cystic fibrosis. These are the patients that often are afflicted with this illness.
Okay.
So it was actually a very logical move, not only what I thought for the medical center, but also for me from a professional standpoint to actually enter that space. And so, we started, my colleague, Dr. Ahmed Hamdi, and I, who is a really, really talented young, energetic infectious disease doctor, who also trained at Mayo, like you.
Yeah.
He and I actually ran into each other, and we just started with the conversation. Why don't we do something together? And now we're working quite a bit together to kind of deliver a new patient experience.
That's great. Now, to be clear, I didn't train at Mayo, but I did practice there for 10 years, and it's a great place. I think all of us seek to go to a place where we can get that multidisciplinary care, where we can have a team look at us and put us in the center
Right.
of what they're doing. So for patients and residents who are training and trying to learn more about it, let's just sort of go across the scope of non-tuberculous mycobacteria. What does that cover? What kind of infections is that?
Yeah, it's a good question. So we think about, NTM as sort of an umbrella term, and then within that, regionally, there's actually quite a bit of variability. So, for example, if you go to New York State, if you go to the Northeast, there's actually a lot of MAC, Mycobacterium avium complex. So if you look at all the NTM isolates in New York, the vast majority will fall under this MAC terminology. And MAC also is an umbrella term. It includes Mycobacterium avium, Mycobacterium intracellulare, and then a lesser common one called Mycobacterium chimera. And I would say MAC, even in Texas, you're still looking at about 60 to 70% of NTM pulmonary cases are going to be MAC in nature. But the thing that we really struggle with, essentially on the Gulf Coast, is we have, mostly due to our, the weather patterns and the climate, we actually have a lot of environmental exposure to Mycobacterium abscessus, and this is really the thorn in the side of any physician and certainly any patient who's dealing with it. It's usually a very highly resistant bacteria, and in patients with underlying lung disease, those on immune suppression, with systemic steroids, those at risk essentially of these environmental pathogens, their experiences can be really, really perilous. And often we'll have to use very complicated antibiotic regimens to sort of manage it, and often we'll have to refer them to a thoracic surgeon to actually resect part or all of a lung to get source control. And I would say between MAC and abscessus, we've got plenty to chew on here where we're at.
So if you have a patient here in Texas that has Mycobacterium abscessus versus a patient in New York that has just typical MAC of any of those three variants, what's the typical course that it'll run? So you'll treat it with antibiotics, and then if that doesn't work, you try another course, and if that doesn't work, you try something else. What are the indications to send that patient for surgery?
Yeah, that's a great question. I think to start off, one thing that everybody should know who comes across or manages is that just because you find it doesn't mean you need to treat it. You really have to put it into context of the patient. And that's why if you look at the American Thoracic Society IDSA guidelines, combined guidelines, it's really the sputum sampling and the actual localization of the bacteria is just a part of it. Okay. You need to have symptoms. You need to have 2 or more cultures positive for the bacteria, or a bronchoscopy sample or biopsy that isolates it. Plus, you need to have a CT scan, ideally a high-resolution CT scan showing evidence of it, which it tends to be one with a high variability in what you can find on a CAT scan. But if you do find it, go on, sorry.
I was just going to say, so you've got to be able to see it,
right?
You've got to be able to feel it,
right?
And you've got to be able to, what?
Yeah, I guess.
Culture it.
Culture it, yeah.
See it, feel it, culture it.
That's true.
Okay,
That's
good.
true. And then, let's say you've made the diagnosis, well, let me stop and say, I always try to tell my patients, I will do everything in my power to avoid having to treat you for this bacteria. Because if you look at the research on this, it's kind of interesting because we actually have very interesting data out of South Korea, which is one of the leaders in terms of publishing on this subject of NTM. There's actually a lot of data on untreated MAC. What happens if you don't treat these patients? And it's about a 50-50 split. About half of them will not progress, and a half of them will progress. So it's really the flip of a coin. And so I do everything I can, including, and most specifically as a pulmonologist, my interest in starting them on airway clearance, breathing treatments that actually can clear mucus, provide some turnover, some of those, that sort of the sticky mucus that these bacteria love to hang on to. Okay. And we have found that we've been able to actually avoid treatment in a number of patients, even when they have persistently positive cultures, because we can keep them symptom-free and we can keep the CT scans stable.
So when people get an infection, I always hear people talking about taking this Vapo rub or doing some type of a thing that makes them feel better to help them get rid of things. But ironically, some of those drugs paralyze those little cilia that help get the junk out of the lungs. And I've always heard that that's terrible to try. Is that true? To take those things that make you feel better, but they're actually making you sicker? Or taking a cough suppressant If you
Right.
take something that gets rid of your cough, but you're actually coughing out these terrible bacteria, isn't that really what you want people to do?
Yeah, I think you nailed it. And the classic phenotype is the post-menopausal woman, because this happens in a 2-to-1 manner.
Wow,
in
I can
women.
identify with that group.
I won't pull on that thread. The so-called Lady Windermere phenotype, which comes from Oscar Wilde
Yeah.
character, and it's usually the thin older woman, very prim and proper, suppressing the cough because they don't want to make a scene in public. That's
Right.
actually the wrong way to approach it. You do want to actually augment cough in these patients because the mucus. The lungs are really a hot, sticky, humid environment. It's just almost made for these mycobacteria to proliferate in.
And you don't want to trap them inside.
Right.
Right. So,
And so-
maybe cough etiquette's really important. So we can
Perhaps, yeah.
teach the public the new, more modern non-Lady Windermere, which is just a really
Right.
good strong cough into your elbow.
That's right, into the elbow. That's right. Especially since what we know about the flu and the pandemic.
Yeah.
But yeah, I mean, medications, bronchodilators, classically albuterol, and hypertonic saline. That's a hill I'm willing to die on to put.
So that's
patients on
salty
that.
water.
That's
just
very
for the
salty.
public.
Exactly. That's like breathing in ocean water, and it's interesting not to go too much into that, but. What you find is that in salt water, which from the oceans, which is about 7% salinity, how much sodium is in it, you generally don't see mycobacteria growing in that type of water.
So it's protective.
We believe, at least in vitro, it's been shown that these bacteria it's a bit hostile for their growth.
Okay.
Whereas brackish water, like you might see in sort of kind of mixture of ocean water and rainwater, lower salinity.
More mycobacteria.
More mycobacteria.
Yeah.
So that's a really big component, especially in those patients with background lung disease who have this. They almost inevitably, unless they have some reason not to be on it, they almost always get started on airway clearance in our clinic.
Okay, and how does that
recommendation,
look when you say hypertonic saline? Are you just taking that ocean spray and squirting it down your nose, or are you doing the neti pot, or are you like humidifying with salty air water?
Yeah, that's a great question. So usually when we do it, I mean, certainly, sinus disease, reflux, and stuff like that can be comorbidities, kind of diseases that go along with people with NTM infection. So you do have to kind of focus on those as well. But specifically when it comes to the breathing treatments, we try to get our saline from reputable sort of medically authorized sources, so usually through pharmacies.
Okay.
And it's a fairly inexpensive medicine. We usually use 7% hypertonic saline.
Okay.
And there's actually a variety of ways. It's nebulized, and it can be combined
And
with
that means
albuterol.
aerosolized. It's brought up into the air by a little
Absolutely.
nebulizer that connects to oxygen or something.
Exactly.
Okay.
It's a little compressor device that basically takes the liquid and vaporizes it so that you can
Breathe it
breathe
in.
it in.
Okay.
And the goal is actually to get it to those distant parts of the lung where a lot of this mucus and this bacteria are sort of hiding, get a cough going and clear that mucus out.
Okay.
And then oftentimes we'll give them maybe a handheld device, a so-called flutter valve, for example, that sort of augments the cough because we really
That
believe.
sort of shakes it off the wall.
Exactly, and we
Yeah.
go as far as to put these patients like we do with our patients with cystic fibrosis, for example, actually give them a vest if all other manners fail. Give them a vest that literally shakes the mucus out of them, and when you combine that with the high saltwater solutions, it makes for a really nice way to get the mucus out of the lungs.
That's great. And you do this for people who have a MAC infection or really any type of infection that you're trying to clear, or to take people who are at high risk, like cystic fibrosis patients, and you want to protect them from getting that infection, and you put them on these regimens.
Yeah, absolutely. And I will say, the data is not the greatest, in the medical research about really the role of their role in preserving lung function, preventing flare-ups and infections. But the data that we do have is supportive of it. It certainly improves patients' quality of life. We believe, based on bigger studies, it does reduce the flare-ups that patients with bronchiectasis get, and is associated with lung function decline. And it makes them feel better, right? Most important, it makes them feel better and allows them to sort of flourish in life, and that's part of our job too.
Now let's talk a little bit about treatment. Are the drugs that are coming out nowadays much better than it used to be? I mean, I remember when I was a resident 20 years ago, the drugs weren't that great for mycobacteria. We knew for tuberculosis we would treat with the RIPE, R-I-P-E,
Right.
rifampin, isoniazid, pyrazinamide, and ethambutol.
That's right.
Is that right? So
That's right.
I memorized that 20 years ago, and I never forgot it, but now I don't really know a lot of the other treatments. But Where are we now?
Yeah, I will tell you that this space, things have been a little stagnant, but I would say in the last 10, 15 years, if you just look at some of these medical journals relevant to the topic, you see a lot of interest in the subject. Mm-hmm. And I think even pharmaceutical companies have recognized an opportunity for what's basically an orphan disease to kind of come in and try to, create something that's game-changing.
Yeah.
But, some of the medicines you talked about are still, for MAC, if you look at the guidelines, it's azithromycin-based usually, is kind of our backbone drug. It's well-tolerated once a day. But rifampin and ethambutol still go on.
Still, wow.
Yeah, and how you use those drugs, it's a little bit dependent on the patient. How bad is their structural lung disease? Are there cavities on the CAT scan? Those make a difference as to, what doses you use and how often you take the medicines.
Yeah.
But there are some, interesting novel medicines out there as well. There was a recent FDA approval about 7 years ago for an inhaled antibiotic, which is the first of its kind, an inhaled version of an old aminoglycoside antibiotic, which is really helpful at dealing with patients who have really kind of tough to treat MAC infection that remain culture positive. But there's a lot of really interesting drugs in the pipeline. So I think over the next 5-10 years, we'll probably see a lot of new drugs come to market to.
Yeah. I just read about a drug, Renovion, that works on bronchiectasis patients with traction bronchiectasis or patients who are transplant, maybe at risk for rejection, and they help with that clearance.
Absolutely, yeah.
Yeah.
Yeah, and there's not to drop names or anything, but there is an FDA approval expected later in the year for a novel drug, an anti-inflammatory, anti-neutrophil drug. Those are the immune cells that are really, really what we believe are the real problem in developing some of their long-term scarring in patients with bronchiectasis.
Yeah.
But we're looking at potentially a late fall approval on a drug, and that's saying something because if switching over to my bronchiectasis hat real quick, there is no FDA-approved drug for management of bronchiectasis, period.
Wow.
Outside of
CF.
CF.
And it's such a big problem.
Yeah,
and it's horrible to operate on patients with bronchiectasis.
You would know, right, firsthand.
Yeah. Those are our toughest cases.
I agree, yeah.
Wow. Well, hopefully we'll be able to get FDA approval for more of these drugs and not have to treat people off-label or do clinical trials to keep trying to figure out what's safe and what's not safe. So hopefully we'll be able to get some more data going down the line. So when you have a patient that has mycobacteria, how do you know that that's what it is? And are there certain things? Like I know in the Ohio River Valley, we tend to have certain types of infections versus other areas. Can you just briefly review for me different regions and what's the most likely thing that's infecting a person based on the region?
Yeah, that's a great question, or a great point, I should say. It's tough. It really does take a lot of time. So the amount of time we have to spend with these patients to sort of pull out details is considerably larger than other patients that I deal with. That's what I have found. So I do dedicate a fair bit of time to each individual patient, particularly on the first go-around, just to, during my information gathering. Mm-hmm. What you want to look for, perhaps even more than region, although interestingly, Hawaii has the greatest concentration of patients with non-tuberculous mycobacteria, and that probably has to do with climate. It has to do with some of the volcanic soils.
Because it's warm and moist?
Yeah, absolutely. Yeah. So that's where, if you look at the epidemiologic data, that's where most of the, from a per capita standpoint, it's the greatest in Hawaii. And as I mentioned, more in the southern United States, so there's not exactly like a south to north gradient like with, other diseases like MS and stuff. But that it really matters. So, we have a higher index of suspicion when, it's a patient from Louisiana or Arkansas or Florida or Georgia along sort of the southern Gulf Coast. But we really are looking for patients with background lung disease. That's kind of an indicator. They've got COPD or they've got known bronchiectasis, probably because we're a big CF center. I have kind of a bad sampling. I have a huge number of patients with CF that I manage. So knowing what the background is, and certainly looking at the CT scan even more than region helps me because usually NTM, in milder cases, you'll just see spots. You'll just see nodules in the lungs. You may not even really see that much bronchiectasis. But in patients with background lung disease, you might see a lot of structural, weirdness to the lung, and then you see a lot of mucus. You see a lot of little nodules. And for
us, that's a nightmare because I'm always looking for lung nodules because I'm thinking lung cancer. And then you start to do a couple of biopsies or you do some cultures, and then you find out, how do you prove if something's cancer versus MAC? For me, that's one of our biggest struggles.
Yeah, and how many times have we, gotten a referral for a patient who was being worked up and had bad COPD, had really bad emphysema in the upper lungs, had a nodule, they got biopsy thinking it was cancer. Patient was prepped for a diagnosis of cancer, and lo and behold, you've got this new mycobacterial thing that you got to deal with. And so I think a lot of it has to do with who the patient is, because the problem is that there's a lot of, we think about what are the risk factors. And unfortunately, a lot of the risk factors that we see come into the clinic are not changeable. They're not modifiable. So age, background lung disease, if they have, or if they, if they're on cancer therapies and are suppressed from an immune system standpoint.
Yeah.
Autoimmune disease, huge one, like rheumatoid arthritis and lupus, because they're naturally taking a lot of these immune suppressant medicines, often really, really powerful immune suppressants.
But like if someone's a keeper of birds, maybe you could change that.
True.
When I was living in Minnesota, we kept chickens. Are chickens as bad as other birds? Are there different types of birds that are higher risk, like a city pigeon? Is that different than a chicken? And which one gives you psittacosis? Is that what you get from the birds?
Yeah, chlamydia psittaci, that's right. So we definitely think more about, from an interstitial lung disease, there is an association between having birds, and I don't want to besmirch the name of a bird, but like I think parakeets, cockatiels tend to be the ones that are like most tied to ILD development. But this,
really,
yeah.
So if you have a cystic fibrosis patient, you tell them probably not a good idea to have a parakeet. Better to have maybe a dog.
Correct. Yeah, exactly. Yeah. And you have to think about the allergy profile and stuff like that.
Yeah.
But the birds, it's all about like bird feathers, the dust they carry, and then cleaning up the droppings, right?
Yeah.
From a fungal disease standpoint.
Yeah.
Some of this stuff is hypersensitivity from the fungus or the mold. So, we do ask about that in our clinics, and it takes a lot for me to tell people to get rid of their animal. I often don't do that, but I try to give them some red flags, what they should need to watch out for. But unfortunately for NTM, it's less to do with animals and less to do with hobbies. So gardening is a big one.
Oh, no.
If you're a gardener and you're kind of knee-deep in the soil, you're kicking up dust and soil from your garden, particularly potted soils. Those tend to have the most amount of mycobacteria because they have enrichments.
Wow, that's really good to know. I had no idea.
Yeah, so that's a struggle because a lot of people love to garden.
love.
And so I try not to tell them, we don't really know exactly how to counsel these folks. I mean, I definitely don't tell them not to garden, but I do tell them to wear, at the very least, a cloth mask, cover their nose and mouth when they're in those environments. Because if you can avoid breathing that stuff in, it's probably better.
Okay.
The other tricky part is NTM loves forming what are called biofilms, which are just like sticky mucus layers. And unfortunately, if you get your water from the city, which almost all of us do,
Yes.
You are being exposed to mycobacteria all the time
Really?
because these bacteria actually colonize the city pipes through these biofilms. So unfortunately, not to scare people, that's not the goal here. It's just to let them know, unfortunately, this is something that we're all exposed to. And so I try to tell people, especially if we found one or two cultures that are positive, they're gardening, they love hot showers, right? Because, the water vapor can carry this stuff.
Oh.
Hot tubs, indoor swimming pools, these are all areas where you might get exposed.
They're just like culture pools waiting to grow mycobacteria.
Yeah, you can find these bacteria in all these environments. So,
wow.
I just try to tell people to be smart about it, and especially if you're in a place where there's a lot of dust or soil, wear a mask. If you're in a hot tub, you could also potentially wear a cloth mask when you're in there. Avoid submerging your face totally. These are things that it's really hard to counsel people on because we don't know for sure whether what I'm telling them to do is going to reduce the risk, but it's sort of best practices at this point.
Yeah.
And we kind of do our best with each individual patient.
Okay, so we have all these risk factors, all these things that are out there. Do you ever tell people, like, absolutely, you cannot be in a certain environment? Anything that we hardcore know is terrible for you?
No, I would say I never tell them they can't do something.
Well, I do. I think smoking.
Well, there you
I think
go.
the combination of mycobacteria and smoking is just the worst.
Totally. Yeah, Absolutely. I would say, the lungs like to be dry, and when the lungs are dry, they're happy, and when the lungs aren't breathing in particulate matter, they're happy.
Yeah.
So, if you've, we rarely see this in the United States, but obviously poorly ventilated kitchens where they're exposed to, carbon biomass burning stuff.
Yeah.
If they're exposing themselves to a lot of indoor grill type stuff, try to avoid smoke.
Yeah.
Of
Well,
course,
Texas
smoking.
barbecue is big. Is that giving you a high risk of getting mycobacteria?
I would say not that we know of from a mycobacteria standpoint,
Okay.
but these fumes obviously are not good if you've got lung problems.
Okay.
But you're right. I think you nailed it. Any type of smoking is probably, it's a huge emphasis for us, right? There's not that many things that we can do that we could counsel patients on that really, really change the course of their life. But if we can get them to quit smoking, right, that's
a big game
that's
changer.
the biggest one of all.
Yeah. Now, what about vaping? Because vaping, to me, has a lot more moisture, and it's got that CO2, and it seems to me somehow it's like blowing this smoke into the lungs or vapor into the lungs. Have you seen any relationship between vaping and mycobacteria?
That's a great question. I've never asked the question. I don't know if there's any research on that. But yeah, I think that what you need is a vessel, right? You need a vehicle to take the bacteria into the lung spaces. And one way to think about this, and we need to probably emphasize this point, which is that smoking, whether you're using an e-cigarette, using a vaping tool, we don't know where these vapes come from, right? They're sourced from all over the world.
They're probably not GLP lab certified.
Probably not. Although I know the FDA was interested in regulating them. But when you introduce these toxins into the lungs, you actually cause inflammation to happen, right? And we know that particularly neutrophilic inflammation, these immune cells, when they get trafficked to these air passages, they indiscriminately damage the airways. And if this happens over a long period of time, you get kind of this structural distortion that we call a bronchiectasis.
Or a cavity.
Or a cavity,
right?
with enough damage. And so...
And sometimes we see a cavity that's filled with fungus, right?
Right.
Like a mycetoma
Right.
is a big cavity that's filled with a fungus ball. And we see those in the lung. And certainly at some point there had to be destruction, or there had to be a space that didn't have good blood supply.
Right, exactly.
Right.
And so what we try to, maybe the way we need to kind of deliver this message is you're inflaming the lung every time you do this. And bacteria love to take advantage wherever there is an advantage to be taken. So they will traffic themselves, and they'll stick to places where the immune system is a bit messed up. And so that, we do know, right, that, smoking does impair the local immune response in the lungs. And so this could be an avenue by which, you can get these unusual infections. And it, may not stop at NTM infections, mold infections, bacterial infections, are all fair game, I think.
So we talked about having these tiny little foci of activity in the lung. We talked about having bronchiectasis. Talk to me a little bit about when the mycobacteria gets so advanced, you've treated it with multiple courses.
Right.
When do you send those patients to me? And what do you think are absolute indications for surgery? I mean, what makes you pull that trigger and say, I need to send this patient for a lung transplant, or I need to send this patient for a surgeon to remove this part of the lung?
Yeah. Let me answer the last one first, which is lung transplant. So if you've got active mycobacterial infection, it's very hard. You really can't transplant these patients.
Yeah.
So how do you approach that? Well, you approach it very carefully. So you try to get them on a regimen that ideally would work based on their cultures and the sensitivities to those cultures. And the real goal there is, especially with the patients with more advanced, whether it's interstitial lung disease or advanced COPD, we have experience at our center with these types of patients. You try to, number one, get their cultures to be negative.
Okay.
And then you want to ideally show that their CT scan is showing some improvement. Once you've done that, then I think there is an avenue to get them to lung transplant, have them see a transplant infectious disease doctor, and come up with the plan. Mm-hmm. Because really the most perilous part is the surgery itself, of course, because there's all kinds of spillage, there's cross-contamination of the inside lung surface. And the worst thing in the world, besides a primary graft problem in a transplant, is a post-infection. I mean, whether it's skin,
because they're immune composed at that point.
Absolutely, you just dropped a nuclear bomb on their immune system as they're being transitioned to that. So, post-treatment, after transplant, keeping these patients on a few months at least of treatment and monitoring through cultures, scans, paramount. We've had success doing this in a very organized manner. As far as as far as surgery goes, And I know you've seen some of my patients
Yeah.
and how horribly complex they can be. The best case scenario is when you've got a patient with local disease. So think about a patient with old tuberculosis who has like a focused area of bronchiectasis where they get an NTM infection that you got to treat.
Yeah.
If that area is a problem spot, especially for patients who have a recurrent infection in that spot, that is somebody I immediately will refer for lobectomy, because that's the goal. I mean, you really, for MAC, the goal is to get them culture negative, keep them on some airway clearance, understanding there's a huge recurrence of infection in these patients, bordering 50%.
Wow.
And so the risk of reinfection is really, really high. And if that happens, I think having a good risk-benefit discussion, getting thoracic surgery involved early is very wise.
And we don't just take out that lobe of the lung. When there's a mycobacterial infection that's not well controlled and the situation's sort of getting out of hand and we have to get it out to get rid of it, sometimes you have to put a muscle flap on top of that or move some fat around in the chest. You always want to cover that because it's still going to have a little bit of infection at the root of that stump. And we don't want patients to get what we call a fistula, which is that stump that doesn't heal and it chronically leaks air and then the lung can't expand and you've got to leave a chest tube in and the drainage problem.
A mess.
This is why thoracic surgeons don't like to take care of these patients because if it does go bad, it can go really bad.
Yeah, absolutely.
Yeah.
Yeah, and I think I would say for MAC, we generally have more wiggle room because we have a lot more medicines in the arsenal that we can use to get people under control. Now with Mycobacterium abscessus, if you look at the guidelines, and the guidelines are mostly expert-based, consensus-based, but surgery has a much more a role in the forefront in these patients because unlike MAC, which, if you've got just nodular bronchiectatic, kind of more mild to moderate MAC lung infection, there's about an 80 to 90% cure rate on these patients, provided that they have, the sensitivities on the antibiotics look okay.
Yeah.
But abscessus, especially when you see a lot of these R's next to the resistance, next to the antibiotics, those are patients that even in cases where I know surgery is probably not going to be doable, technically, I still refer them.
You may ask.
I may ask. It's
sort of a Hail Mary.
That's right, because there's a bevy of different opinions. You get 10 surgeons in a room, you're going to get 5 or 6 different opinions about what to do there because we really don't know.
But if you can technically, surgically remove it early, that's the best way to get in front of it.
Absolutely.
And then to try to eradicate it. And it's a risky surgery. Right. It's always difficult. The scarring is tremendous. Right. But if you can get surgeons who are skilled enough to get those things get those things out, that does give you a little bit of an advantage.
I totally agree. Yeah. And I have to admit, some of the surgeons have been extremely impressive with what they've been able to do. So we've had some patients that have had complete pneumonectomies because they had so much lung damage in one lung, a spared second lung, and so the conclusion was, in order to give this patient the best chance to flourish and actually overcome this infection, you just got to take the whole lung out. And we've done that on a few occasions, mostly with success.
Yeah.
But these are not small situations, and they really do require a multidisciplinary approach. So, from my
highly
vantage point,
selective, multidisciplinary decision, not taken lightly.
And we have the advantage that you guys, you're 2 floors down from us. So, I've been able to, thanks to your amazing team, we've been able to quickly get them on the phone while the patient is there and say, hey, can you see this patient now?
It makes a big difference.
It makes a big difference.
Yeah.
Patients love it, and it's of course, it's very efficient for the patient too.
Yeah, great. Well, thank you for all that you do. There's so many wonderful things that I've learned just in this podcast. We're going to have you come back and talk to us a little bit more in depth about bronchiectasis and maybe again and talk about cystic fibrosis because I know all of our listeners are really eager to learn as much as they can about lung health. And we'll talk about more prevention and sort of some common sense tips. But thanks again for joining us. Any last minute words you want to add?
No, I would say, for the trainees who are out there, there's a mantra that I think everybody should live by, which is do what you can with what you have where you are. And so, yes, the physicians across town maybe have a lot more resources than you, but, take advantage of what you have and try to build things. That
makes sense. And always our group is very collaborative, happy to help other groups that might not have as many resources. That's why we're here. Yeah. All right. Well, thanks so much.
Thank you so much for having me.
Yeah, loved having you. Thanks again for joining us at the Baylor College of Medicine Lung Institute podcast on air.